Anyone have any questions from last time? So I'll hopefully get through this in a timely manner today, and then we'll do the review tomorrow. It should only be an hour, so hopefully you guys will get out a little earlier because of that. So we'll do what we can. And then what happens after spring break? Huh?
What happens after spring break stays after?
I don't know. My test is really my first concern to be like, how's that going to work out? But I don't know at this point. The exec team has it covered. They're working on a plan right now. Worst comes to worst, I can record my videos and post them online, so that's not going to be any different than, or it shouldn't cause any kind of delay from that standpoint. But fortunately, I've been practicing social distancing my entire life. I mean, junior prom, senior prom, my wedding. I mean, like, it was, I got this down. 2 weeks, nothing. Kidding. So any questions on, this is a pretty appropriate topic given circumstances and whatnot. If only we had a vaccine, but unfortunately no. Although I did hear an uplifting story about the coronavirus. Someone who had caught it actually found a significant other while in their hospital stay. That person had Lyme disease. So, anyway, match made in heaven. Regardless, okay. So just a little bit about the history of vaccines. They've been around for quite some time. We've kind of, it took us a while to kind of figure out what was happening in these patients here. So for instance, back in the 1600s, we were even inoculating ourselves with smallpox. And they found that by transferring pus from one infected person to a non-infected person, they could actually develop immunity. So fortunately, we've gotten a little more sophisticated than pus transfer from these days. Although we still do fecal transplants occasionally, right? So again, medicine sometimes stays a little gross. But regardless, anyway, we kind of from then on would realize that, for instance, things like, milkmaids who had contact with cowpox actually did not get smallpox, for instance. So there is some cross-reactivity in some of these cases here. And actually, vaxa comes from the Latin term for cow, which is kind of interesting. When you think of a vaccine, it's like a cow scene, essentially, right? And so since then, we've been able to develop quite a number of different types of vaccines to different things. Some of these are going to be things you'll get routinely. Some of these things are very sort of situational, and we'll talk about some of those. Basically, I'll cover sort of a background in terms of like immunizations and some of the concepts behind it, and then we'll dive down into some specifics, some kind of highlights of different types of vaccines you run into with some regularity, or some that are more situational. But you can see here that again, we don't get immunity against all of these necessarily, but we may have some of these that are done situationally. So if you're traveling in certain areas, you may get them. If you have a certain contact, say for instance, if you have, say, a wild mongoose were to bite you, you may be concerned about rabies, right? And so in that case there, you may have to get vaccinated against that. Sometimes, again, it can be situational. And so just to give you an example of one instance of how effective vaccines can be. Everyone here believes in vaccines, I'm assuming? Hopefully you're not too scared to raise your hand. Yeah, they're not going to say if they don't. It's okay. I don't believe in it either. That's really the joke. Vaccines. Am I right? I'm just kidding. No, they're good. Everyone should get vaccinated against everything. But just to give you an example of what polio looked like, if you look at what the official coverage versus what the actual WHO estimated coverage in terms of polio vaccination here, you can see the actual number of cases goes down quite significantly. The point being here, though, is that once these cases are all gone, you can just stop vaccinating, right? No, right? Because then stuff comes back, and there's been some cases of that, and I'll show you just a few examples in just a moment here. What are some reasons people don't want to get vaccinated, though? Yeah, they're worried about autism, right? They're saying, okay, I might get autistic if I get vaccinated, or my children might become autistic, which I think speaks a little bit more to the social stigma against autism than it does anything else about vaccines, which is kind of a bummer. But being what it is, we'll talk a little bit about why people are concerned about that. We'll mention that a little bit later on in terms of like what the CDC has to say about that. What are some other reasons? Maybe they have allergies that may preclude them from certain types of vaccines. We'll look at a list of different types of allergies that patients may need to be aware of, or we need to screen for to make sure they don't get certain types of vaccines. What else? Maybe religious beliefs, potentially, yeah. Certain types of immune globulin we'll talk about as a form of passive immunity. Patients may not want to receive because they're gathered from donated serum, right? So if you donate plasma, we can isolate out certain antibodies and then That would be a foreign product. Certain Jehovah's Witnesses would not be able to receive that, for instance. There are lots of other things too. So just like, I don't really have time for it. Everyone else is immunized. Why do I have to really worry about it? Fortunately, we've been expanding access in the past several years. So for instance, when I was in school about to graduate, which again, it was about 10 years ago, self-esteem down there. Anyway, we were just doing, we had just gotten access for pharmacists to do the flu vaccine, right? So it was a relatively new thing, and since then it's been expanded. Did I ever tell you about the first time I gave a flu injection? It was in our lab as a practice, because against retail pharmacy kind of thing, so I've never actually done it in practice to an actual patient. But we had a lab, we were giving test doses to our fellow students, and they're like, okay, just make sure if you give the IM injection, you hit the bone. Don't make it like known you'll feel it, but don't make sure you don't put it on your face, otherwise it'll freak out the other person. I said, okay, so I did it and immediately hit the bone, and then I was like, ooh. And then they're like, what'd you do? And I was like, ooh, don't worry about it. It was not great. Again, pharmacists are not great for practical purposes, but we've gotten a lot better at vaccines since then. So you can go to Walgreens, you go to CVS, you can get a variety of different vaccines. So increasing access is a good thing there. And yeah, the whole herd immunity thing is something that people really rely on. But again, as the herd gets thinner and thinner, then your risk for outbreaks tend to increase. So as an example here, back in 1974 in Japan, they had a pretty successful pertussis program. They had roughly about 80% of children getting vaccinated, and they only had about 393 cases reported that year, and actually no deaths associated with that, right? And so after a while, they said, well, we don't really need it, and there were like rumors that the vaccines were not safe. Maybe there's some social media pushes back in 1970. I don't know what social media was back in 74. Maybe there's something out there that said, don't get this vaccine. And so by 76, only about 10% of those kids were actually getting vaccinated, down from 80 to 10. And so what they ended up seeing is they had more than 13,000 cases pop up, and then actually had several deaths associated with that as well. So since then, they said, okay, well, let's just make sure we are reinforcing this, make sure everyone gets vaccinated to try to prevent these sort of outbreaks from occurring. And so we know that these prevent a lot of disease. We know that, for instance, certain cancers can be prevented. Anyone know any examples? HPV is a big one that can prevent what type of cancers? Cervical. Any others? Like colorectal cancer potentially, with certain strains of HPV we'll talk about later on. How about like hepatic cancer? Right? Yeah, hepatitis A and B, we have vaccines against. So again, different diseases that can be prevented, can be cancers even in these cases here. So a lot of reasons why we want to make sure patients are vaccinated when it's appropriate, right? Just so you know, this is an updated version, so if you haven't downloaded that, I changed a couple of slides, so just FYI from the one I originally posted. So anyway, so getting into different types of immunity, we know we have passive versus active immunity. What's sort of the difference between those two? Passive is that our body is actually generating the immunity itself? Not really, right? Active would be if we're actually developing our own antibodies. Passive tends to be more of a sort of, a temporary sort of thing, but can be very helpful, especially in the short-term sort of instances. The nice thing here is you get immediate protection. There's no period of time where the patient's not being protected when they have a degree of passive immunity. It may only last weeks to months, depending on how long the product happens to be sitting around for. So for example, if you have immune sera, so if you have like a human source, so you think a lot about like breastfeeding children, getting antibodies from the mom that does keep them protected for a period of time, that actually has an impact on what kind of vaccines they get, which we'll see in a little bit. We use a lot of immune globulin for different purposes. So this is actually from actually donated sources from patients who have donated plasma. We can actually get immune globulin from that, and so make sure we sterilize that, make sure it's plenty safe for these patients, but we'll look at some examples of that later on. You can even have antitoxins that are developed here. So we can actually have, for instance, animals that have been hyperimmunized against a certain target and then isolate out those antibodies and then administer that to a patient. In fact, we have a lot of different animal sources for that. So for instance, we have equine sources that are coming from horses. When we talk about, for instance, snake bites, right? Is that a problem here in Florida? So if you have venomous snake bites, there's different types of antivenom we can give, and some of those are coming from ovine sources. You know what ovine is? from sheep, actually. Yeah, so actually sheep were hyperimmunized against certain snake venoms, and we could isolate that out and then give that to patients, provide sort of a passive protection against those particular toxins, right? And so we'll talk about different examples, but obviously if you were to look at, say, patients getting immune globulin from a human source, say, versus antibodies from, say, a animal source, which one do you think would be more risky to administer? Or the animal source, right? Foreign proteins are always going to be more immunogenic, so that's going to be a big risk. We'll see with those. And frequently we'd have to give patients, say for instance, like the coral snake antivenom that we have here is a horse-derived antibody, and we actually have to make sure we do skin testing beforehand. So we actually will do like a little intradermal test dose just to see if the patient's going to have a reaction, and if they do, sometimes it's like, okay, well, do we just treat them through the anaphylaxis? And oftentimes we end up doing that because we know that the risk with coral snake envenomation is a lot worse than just having an anaphylactic reaction, but we'll talk about that later. Anyway, with active protection, this is where a patient's own immune system is going to be producing this against a delayed sort of response. You can see there because it takes time for the body to recognize the antigen and develop the antibodies. And the durability can be dependent on the type of vaccine they're receiving. So, and when I talk about durability, that means how long is that patient going to be immune from that particular disease state or bacteria or virus or whatever. Some cases lifelong, sometimes it's going to be more limited, which in some cases you have to get things like booster shots later on to try to sort of sensitize the immune system to that. And then natural disease itself can help provide this nice active immunity. Obviously the most effective way to develop immunity is what? Just get the disease itself, and then you're pretty well protected. Vaccines are going to be certainly secondary to that. Anyone ever have like a chickenpox party where you just all put all the kids together? Yeah, it's kind of like a more old school sort of thing, but that's something that has been done before to try to make sure kids develop their own immunity, and then they don't have to worry about it later on. So how we can predict how well the patients will respond to our vaccines can be a lot of different factors go into this. So looking specifically at the actual vaccine itself, you can look at the actual viability of the antigen, whether it's going to be a live attenuated versus an inactivated form of the virus or bacteria. When I say live attenuated, what does that mean? Yeah, it's kind of like a wimpy version of the same bacteria or virus, right? So it's still alive, it can still replicate, but it's going to be in a weakened state. Versus an inactivated, it's usually like a killed virus or bacteria, or it's actually just a portion of it, as we'll see some examples of this in a little bit. We'll look at the dose of the antigen, especially if we have to give a repeated dosing. That does certainly help out with having a good response to that. And then the type of vaccine. So for instance, when looking at whether we give polysaccharide versus protein polysaccharide vaccines, especially in infants, we'll see that actually makes a difference in terms of how good of a response they have. So with infants, we assume that their immune system is going to be pretty well developed or sort of underdeveloped. Pretty underdeveloped, right? So it makes sense. How well they can bind on to certain antigens can be dependent on what it's kind of mounted to. And so some of these different types of vaccines will find that what we mount it to, whether it's just a sugar molecule or maybe it's a protein plus a sugar, that can actually have an effect on how well they have a response to that. Even the site of administration can play a difference here. So whether you give the hepatitis B vaccine in the gluteal area versus the deltoid, you'll find they have better responses by giving it in the deltoid in a lot of cases. So even that can make a difference. In terms of host factors, this is certainly important here, and we consider age to be a big factor here. Who would have sort of the least response to a vaccine, do you think? Probably the elderly, because their immune system may be a little more compromised, and the very, very young, right? Especially when you kind of think about the really young, especially if they're still being breastfed, they're still getting a lot of passive transmission of antibodies from the mom. That can actually help to reduce a response a patient may have to a vaccine. So you'll see that certain vaccines aren't even started until month 12 when we're sure that the mom's passive immunity has sort of left that particular child. And so also look at things like intervals between immunizations or certain time frames you should adhere to. Typically, the longer you wait, the better response you're going to get. You don't want to give things too soon because you'll find that have a decrease in response. And then coexisting disease, right? So you want to think about things like if a patient's already sick with something and their immune system kind of heightened to fight that off, maybe your vaccine is not going to be all that effective because the immune system can't really just focus on that. So sometimes we'll try to, based on comorbid conditions, try to schedule things out a little differently. And I'll show you some examples of that later on. So talking about the types of vaccines, we've alluded to a few of these already. You have the live attenuated, which have been basically cultivated to disable their virulence, right? So they should not be able to cause the actual disease in and of itself. But the response that you get the actual active response your body develops should be pretty similar for the most part. So for instance, if you think about the live attenuated flu vaccine, right? There's the flu mist that you get, the nasal spray is a live attenuated form. And so a lot of times you hear people will say after they get their flu shot, what do they always say? I got the flu after I got the flu shot. You'll find that's not really the case. What you're finding is that the body's still having an immune reaction. They're still having some of those symptoms, but it should be a much more mild form than if they were to get the legit flu that is in its full kind of strong state. Getting into the killed or inactivated form, this is either the whole microorganism that's either been killed by a chemical means or they've used heat to disable it. Those typically require more repeated dosing because you don't get the same sort of response to it, because if you think about a live attenuated form, they can still replicate and you can still get a good response to that, versus this killed one, it's not doing any replication. So it stands to reason you have to give more doses as time goes on. Then you can have fractional versions of this, where basically we just take a portion or maybe a portion of an antigen of one of these bacteria or viruses that we can then try to mount it onto something else that our body can have a response to. So for instance, we can have things like toxoids, where actually it's not against the organism itself, but something that a product that organism releases. So when you think about the tetanus toxoid, that's what we're actually having a vaccine against at this point there. Sometimes you're using just a subunit or just a portion of that. And then these tend to be more protein based. And again, most vaccines are given via which route? Most are injection. Are there any oral vaccines? Yeah, rotavirus is an oral, and then any intranasal ones? I just mentioned one. Yeah, the flu vaccine, for instance. So those are all protein-based, but sometimes we'll have ones that are going to be conjugated vaccines. These are going to be more polysaccharide-based, where you can actually take a long sugar molecule, add on that antigen to it, and that helps the body have a better response to it. Maybe it's too small on its own, but by giving it something bulkier to kind of mount to, that helps our response to it. In some cases, we'll have recombinant forms, where we can actually have things like yeast molecules actually produce the antigens itself, which can be somewhat helpful, and we'll talk about some instances where that can be useful. And then we talked about the immune sera. This is basically donated plasma, IgG, that patients have donated that we can give to patients that does provide some passive immunity. We'll talk about some instances where that can be useful. So other components you're going to find here, and this is again where you get into a lot of the sort of debate you'll find on places like Facebook and other things, where they say, look at all these things they include in these vaccines, this is so terrible. There's a lot of other active or inert ingredients you're going to find. When I say inert, that just means what? It's not very functional, doesn't really do much. People describe my teaching style as inert. I said that was quite rude. But there may be other things. There's water, there's saline. Albumin may be used sometimes as a vehicle, something for the actual product itself to be dissolved into before injection there. There's stabilizers, preservatives. One of the big ones that was a big concern that was thought to be linked to autism was this thimerosal. It's actually a mercury-based product. Now, mercury itself, is that good for your body? No, it is not, especially when it's in the organic form. And that was some of the concern. They said, oh, look, there's this organic mercury that's in here. But again, the form of the mercury itself, it actually makes a big difference. And so we'll talk more about that a little bit later on. Patients may have allergic reactions, and it's not necessarily to the actual vaccine itself, it's to these other products here. So for instance, there may be egg proteins that are present, there may be latex molecules that are present that patients may be having reactions to, and that's why it's important to screen for those things. I'll give you a list of things we can look at going forward. And then looking at different manufacturers, that even can have a difference in terms of which inactive ingredients are present. So just because a patient has a bad reaction to, say, a Pfizer branded vaccine does not mean they're going to have an issue with a Lilly branded vaccine, for instance. So there is some differences between the two. Okay, so getting into specifics in terms of live vaccines, again, these are going to be usually an attenuated form of the wild virus or the bacteria itself, and it needs to be able to replicate in order to survive. Again, the immune response should be similar, the host response should be similar to what the actual infection would look like, which is why you can get things like fever, low-grade fever associated with this, myalgia, things like that. You'd expect, because again, the body's having an immune reaction. It's just they don't get the full-on disease in and of itself. The durability of the response tends to be much better with these, and so sometimes you only have to get a one-time dose of a particular vaccine and then you're kind of done. You see that more often with the live attenuated forms. Other things we think about is that they can be unstable, meaning that we think about things like shelf life for these, how they're stored. Oftentimes, you guys ever heard of the process of lyophilization? That means when you freeze dry something. So if you ever find a drug that comes and it looks like in this little, like almost a cake of powder, in a vial, you have to reconstitute that. That's why we do that, because it actually helps us with the stability of that. So you're like, it's this little powder in a vial, like how am I going to get that to a patient? Well, you reconstitute with saline or something, and that does help out with that. Usually things in solution tend to be more unstable just inherently. But other things to consider is that it could interfere with circulating antibodies, and so this will become important when we talk about things like rabies vaccine or things that have antibodies we can actually give for that. So we'll talk about some examples, because again, if you would imagine if I were to give someone an antibody, say for instance against tetanus, okay, I give them the antibody to try to neutralize any tetanus they may have available, and then I give them the vaccine for that. What do you think could interfere there? What can happen if I give a live attenuated form? The antibodies are going to attack the actual live attenuated form. So because of that, you may find that would neutralize it. So there is some dosing considerations we'll look at and how you can separate those out and when it becomes relevant. Of course, you do want to be cautious in patients who have immunocompromised states. So if they're receiving chemotherapy, if they're on immunosuppressants for things like, say Crohn's disease or rheumatoid arthritis, pregnant women you want to be cautious with because it could have some effect on the fetus. And then infants, again, these are the ones you want to be really cautious with because of their immunocompromised state, right? Not the pregnant women are immunocompromised, but again, you worry about the fetus not having good protection necessarily. Because what could happen to those patients? They could get the disease itself, right? That's the big concern with that. So just some examples of live ones. We have things like viral versions for measles, mumps, and rubella. You have varicella and zoster. The intranasal influenza in particular is going to be a live attenuated form. And then rotavirus is another common example. Now, I'm not going to ask you on a test to say, okay, the MMR is what type of vaccine, right? Because I don't really care that you know that necessarily. I'm also not going to ask a lot of questions on specific scheduling questions that may come up on a PEDS exam. I don't know what Professor Shales is going to do. Because again, when you look at vaccine schedules, like what can you always do? You can just look it up, right? And especially if you work in PEDS, like, you're just going to know it after a while anyway, just because you do it over and over again. But what I'm going to be focused on is more of the conceptual issues here with these viruses, with these vaccines. So if I say something like, you give a live attenuated form to a patient with immunocompromisation, what could happen? That's too basic of a question for me. I'd ask something a little bit more substantial, but you can get the idea of what kind of concepts we're looking for here. Examples of bacterial forms would be something like the BCG vaccine. Anyone know what that's used for? Yeah, for TB, which we don't routinely get here in the US. We may find patients who come from other countries potentially have that. They usually test positive for PPD tests, and they usually have to get follow-up chest x-rays and whatnot, oral typhoid, things like that. Getting into the killed or the inactivated forms, again, these do not replicate or cause disease in the patient. They really have no risk of doing that because, again, they're just not a live version of that virus or bacteria. And you'll find that inactive antigens tend to have minimal interference with circulating antibodies, so I don't really have to worry about that quite as much as I did with the live attenuated virus or vaccine. Larger doses and typically repeated doses are going to be necessary in order to get a good durable response with this, and sometimes even then we have to look for titers later on, years down the road, to make sure you still have good antibody levels, because otherwise we'll have to end up giving you another booster in order to get that back up. So again, the immunity is temporary, I should say, and generally requires about 3 to 5 doses, and that can vary depending on the vaccine that we're giving there. And you tend to have a pretty decent response, pretty good protective response after the 2nd or 3rd dose or so, but why do we keep going after that? So by re-challenging the immune system those extra couple of times, you increase that durability of response. You make sure that patient, or maybe if you have a few people who are not fully immunized after that 2nd or 3rd dose, you make sure you capture a larger percentage of them. So that's why we end up giving multiple doses there. As I said, we give booster doses occasionally, and that helps to sort of retain those B cells, make sure they have that immunologic memory, so that way if they ever do get exposed to the real deal, they would have the ability to mount a good response to that. So a lot of examples of this, of the killed or inactivated forms. You have things like influenza. This one's not available in the US anymore. We'll look at some other varieties though. Things like rabies and hepatitis A. So a lot of different varieties of killed or inactive vaccines we have available to us. So looking at other varieties, you have polysaccharide vaccines, and again, these are just long sugar chains that the antigen has usually been mounted to. or it could be just a component of the actual bacteria or virus itself. These are going to find, if it's just a pure polysaccharide, you tend to find, especially like in patients with poor immune systems, like kids less than 2, they actually have almost no response to it whatsoever. They just can't really mount a good response to that. And so sometimes what we'll end up doing is using a conjugate polysaccharide. We actually put a protein along with the polysaccharide, and that provides a much easier time having a response to that. So even kids as young as 2 months of age can have a response to this, and you'll see examples like the HIV or pneumococcal being a conjugate polysaccharide vaccine. You can see that on the vial itself. It'll give you that name. It'll say conjugate polysaccharide. We have a few recombinant vaccines, and so this is going to be basically where we have engineered, say, for instance, like E. coli or yeast or something, in order to produce just pure antigen out of those cells, and we can isolate that and give it to the patients. So, for instance, like hepatitis B or HPV tend to be from a recombinant source. They tend to be a little more expensive to produce depending on the situation, and so if we have the option of giving like a live attenuated versus recombinant, you'll typically see we'll go with something like a live attenuated, just because we get better responses out of that, and typically cheaper to engineer in a lot of cases. We have a live attenuated recombinant vaccines. This is definitely not commonly given, but things like typhoid, but the most common one you're going to run into tends to be the intranasal influenza, or that flu mist. You'll see being used pretty commonly. So as a general rule, so we're talking about timing and spacing of vaccines together. Really all vaccines can be administered at the same time as any other vaccines. If you have a patient coming in, say like, I don't know, like a 12-month-old or a 18-month-old, they can get all their vaccines at the same time. There's not going to be any sort of interference between different vaccines being given at that point there. Question is when you have, say, multiple vaccines you want to give, or sometimes what I'll see with patients, especially their parents, are really concerned about getting all these vaccines all at once. They'll go on a delayed schedule where they may try to space out the vaccines that are getting over the course of several months. This is where this becomes more important. So, for instance, if I were to give 2 inactive vaccines together, I can give those 2 simultaneously. That's no problem, as I said with that general rule. But if I say I had one patient come in, say, on month 1, to get an inactive vaccine, and they come back at month 2 get another inactive, that's totally fine. They can get those at any interval, no problem. The issue with is if you have 2 or more live vaccines, if they're not given at the same time, you have to wait at least 4 weeks. You couldn't do that by, say, 2 weeks, because the body's still having a response to that first live vaccine, then it may not be able to mount a very good response to the second one. Okay, that's kind of the general rule, is that if you have 2 more lives, you have to separate those out by at least 4 weeks. If it's an inactive and live, no problem. 2 inactives, no issue there either, okay? Or if they're all coming at the same time, they want them all at the same time, no problem, right? So looking at the multi-dose vaccine series, we see pretty commonly with several of these, again, the minimum time you're going to see between dosing is going to be 4 weeks. But what you'll tend to find, that's the minimum, right? We can extend that out pretty greatly depending on the situation. So typically, you're going to see between the next to last and the last dose, we like to end up waiting about 5 to 6 months or so. What do you think that is? Yeah, giving it more time to kind of settle down, and then you re-challenge that again, and they tend to find a much more durable response there. So that's why we'll look at some dosing schedules here for different vaccines in a little bit, and you'll kind of see what that looks like as we go forward. What you're going to find is an increase in the dosing interval does not necessarily diminish effectiveness, but it may delay the response in those cases there. So say, for instance, you're supposed to get the first 2 of the series, say 4 weeks apart. By delaying that, overall, they'll still get the same immune response. It just may be a little bit slower in order to develop that. It just depends on the situation. Now, what if a patient came in, and they're supposed to come in, say, 6 months after between their second to last and last dose, and they came in at 7 months? Do I have to restart the whole series? Typically, no, as long as it's within reason. If they came back and they're like, yeah, 5 years ago, I got my second to last dose of something, can I get the last one? In that case there, I might want to restart them on that, because, again, you want to think about within some reason there. So you don't necessarily have to restart or really add any doses as long as it's within a reasonable time frame. So a couple months, no problem, typically. Okay, so as we're mentioning here, immunosuppression may actually reduce live vaccine efficacy, and also additionally poses that risk they may actually get the disease in and of itself. So if you don't have a competent immune system to respond to that, especially live attenuated forms, they just won't develop immunity to it in the first place, and then they could get the disease itself. So for instance, we may try to space these out as best we can. So for instance, if we know if they're going to go on, say, radiation or chemotherapy, we could try to vaccinate, say, 2 weeks beforehand, or we may actually wait about 3 months afterwards to give the immune system time to reconstitute itself before we administer that vaccine. So that's a general rule of thumb there. We've talked about this before with certain autoimmune diseases, like, for instance, rheumatoid arthritis or like multiple sclerosis. We were talking about the disease-modifying therapies and how you didn't want to give live vaccines at the same time they were receiving that. You either want to do it a little bit beforehand or wait for a few months afterwards. And that same sort of mantra goes into play here in terms of trying to make sure that they do have a good response to that. Now, again, if you were to give, say, the actual antibody itself, the actual immune globulin against a certain disease, and then you have the live vaccine as well, typically if the live vaccine is given first, you want to wait at least 2 weeks before we give the antibody. The reason why we do that is we want to make sure the antibody doesn't go and just inactivate the virus or the bacteria in and of itself. We want to give it time to replicate and actually cause an actual durable immune response there. If it's less than 2 weeks, then what we can actually do is actually test for immunity, see if the patient has any titers there, or we can actually end up repeating the vaccine if need be. So you may have to restart that for those patients there. And then if the antibody is given first, then you have to wait about 3 months or so or longer before you can actually give the vaccine. Because again, those immune globulins, they're big proteins, they stick around for a long time and provide nice passive immunity for that period of time. So if I were to give the vaccine afterwards, you don't really see a whole lot of good effect out of that. So we'll look at some examples of looking at, say for instance, like rabies dosing of the vaccine and the immune globulin and see how that actually plays out in practice. So in terms of contraindications and precautions for these patients here, so if you see C here, that means it's a contraindication. If you see P, that means a precaution, so you should be maybe a little more cautious before vaccinating that particular individual. And then V stands for vaccinate. Go ahead and just give it to them regardless. So looking at this, so if you imagine a patient has an anaphylactic allergy to a component of a particular vaccine, so maybe they have an egg allergy, a severe egg allergy, and they know that there's an egg component in that vaccine. Should you give that vaccine to that person? No, obviously we can try to find an alternative if one is available. If they've ever had encephalopathy either by itself or related to vaccines, certainly that's a contraindicated as well. And again, this is live versus inactivated. So where it gets a little bit more dicey is going to be with pregnancy. Now pregnancy, we do not want to give the live vaccine to those patients because again, we worry about it developing in the fetus because they don't necessarily have a good immune response there. But if it's an inactivated vaccine, you can go ahead and vaccinate those pregnant patients. So for instance, when we have pregnant patients come up for their yearly flu vaccine, do we give them the flu vaccine? Yeah, we give them an inactivated form of the flu vaccine. They may not get the flu mist, which is a live attenuated form, but we'll give them maybe the intramuscular shot, which is a killed version. If they have immunosuppression, you can give them the inactivated vaccine. That's probably okay. They're not going to get the disease from that. However, are they going to have necessarily a good response? No. So you can always give it to them, may get some response out of it, and then you can test for immunity later on and maybe redose them if need be. But there's no inherent danger of giving them the inactivated form. So again, questionable efficacy, but overall, if I was concerned with that immunocompromised patient actually developing any diseases in the first place, it's probably better to hedge your bets and just go ahead and vaccinate with a inactivated form. Obviously, we don't want to give them the live form because, again, we worry about them, one, not having any response to it, and then two, getting the disease itself. If they have any severe illness at the time of vaccination, if you have time, go ahead and hold off. Maybe wait till their illness resolves and then dose them. You may find a diminished response if they're fighting off some other infection and you try to give them this extra sort of load on top of that. It may not be able to really devote a lot of attention to that from an immunologic standpoint. And then if they receive any recent blood products, why do you think this would be an issue? Yeah, they might have gotten antibodies from that donated sample there. So that patient may have been vaccinated against something and they already have antibodies against that. Here, it's again a precaution. It's one of those things where you'd have to maybe do follow-up testing to see if they develop immunity against that. But if it's an inactivated form, we don't really have any issues with that. Just go ahead and administer it because it really doesn't interact with the antibodies all that significantly as it turns out. Again, there's a lot of different products that will be included with these vaccines. And again, I'm not going to ask you specifically which one of these has gelatin in it, which one of these has neomycin. Again, you can look this stuff up and you'll be screening for these prior to administering, or maybe like your nurses or MAs or somebody will be asking these questions beforehand. But just to give an example of different things that patients may have allergies to, include things like egg proteins, right? So especially if they have really severe allergies to eggs, not just like, ew, eggs are gross. They have to have a true reaction to that, and then that would be something to watch out for, right? So certain varieties of flu vaccine, it may contain egg proteins. We definitely screen for this one most commonly. Again, we'll talk about flu a lot. And why do we talk about flu so much? Comes up every single year. What'd you say?
It's a big killer.
Yeah, well, as long as you keep people vaccinated, hopefully you have to limit that to some degree, but it's something that comes up every single year. Like some of these you may only get it one time and you're done, but flu comes up every single year. We always have a new variety, and we'll talk about that a little bit later. But we have other things like latex. They have a severe latex allergy. There's a lot of vaccines that do include that. So again, another thing to screen for, another thing to watch for. Some of it, maybe just you watch the patient for an extra maybe 15, 20 minutes after they receive the injection just to see if they have any reactions. Some of them, if it's a really severe allergy, then you may look for alternatives. Certain things like neomycin, streptomycin, we know these to be antibiotics to help keep the stability of the product. Again, you find these kind of invariably in different products there. Interestingly, there's a cross-reactivity of some patients that have an aspirin allergy. They may have an issue receiving the live attenuated influenza vaccine, so it's kind of a unique one that may come up year to year. So we talked about administration, and many routes are available. So we talked about subcutaneously, intramuscular, probably going to be the most common varieties you're going to run into, but certainly there are other options. So like oral for the rotavirus. Again, we give this when the kids are quite young. And you think like, okay, well, a vaccine is usually kind of protein-based, wouldn't the stomach just chew that up? Really young kids, though, you tend to find they still can have some translocation of those proteins. They can still get decent vaccination out of that. So that's really kind of a rare case for that. And then the intranasal formulation for, influenza. That's kind of nice because if patients are pretty needle phobic and they're really worried about, they get really anxious around needles, this could be a good alternative to them. It's just a nasal spray. Typically, in terms of injection sites, the anterolateral aspect of the upper thigh is pretty good for infants and toddlers. Most other children and adults are going to get it into the deltoid, so there's no problem there. And then we generally avoid the buttocks, mainly because we've actually found that for certain vaccines, they actually get inadequate response from that, so they just avoid that altogether for the most part. What kind of adverse reactions can you expect to see from vaccines when they're given? Typically, a lot of it is located to sort of local pain, maybe some swelling. And we got their tetanus shot recently. That one was caused my muscles always my shoulders really sore after that one. I had to get it prior to my first child being born, right? Because you're worried about pertussis risk, and we'll talk about that a little bit. But you'll see that pretty commonly with inactivated vaccines. Pretty mild, off-limited. That can take some Tylenol, no issues, right? Systemically, again, you're mounting immune response. You see this more often with the live attenuated forms, but you can see some fever, some malaise, some headache. Again, just treat it supportively. It's going to be much more mild than if they got the disease in and of itself. So that's always a good counseling point for those patients there. And then true allergies to vaccines is quite rare, but we can minimize that risk by doing appropriate screenings. And most patients will have to fill out something prior to getting a vaccine anyway, just to screen for that stuff beforehand. What would happen if a patient did have an adverse effect, right? So there are monitoring systems in place to make sure that we can identify these things, especially when you have a new product coming out every single year, like the flu vaccine. You want to make sure that we can monitor for issues that are cropping up that maybe we didn't test for or we didn't see in, say, in clinical trials, for instance. And so this is where we had the Vaccine Adverse Event Reporting System, or the VAERS system. And this is where we actually will be monitoring through the FDA, looking for the adverse effects. You can report that. Anyone can report that if an adverse effect would occur. And then they can do further investigations to see, okay, was this really related to the vaccine? What's really going on? Are they getting a bunch of reports popping up for the same thing? That's one way we can monitor for that. And there's even a vaccine injury compensation program to where if someone did have a true adverse reaction, a true injury as a result of this, they can potentially get compensation. So there are things in place to try to help out. And again, maybe this is a good way to ease the minds of patients who maybe are more hesitant to get a vaccine. They're worried about adverse effects. Like, listen, we're monitoring for this sort of stuff. If something was going to happen, we would have seen it by now. So just some examples, a way to try to calm your patients' worries there. All right, now to get to the real part of the lecture. I'm going to cut off the recording here. We talk about it for real. Vaccines, look at all the stuff that's contained in here. Look, potassium chloride, it's a neurotoxin. I want you to all get rid of all your potassium chloride out of your systems right now. No. Right, so you'll see a lot of stuff like this, and it can be quite powerful to certain individuals, especially if they already have a preconceived notion against vaccines. And so it's a big challenge to try to educate patients and try to convince them that, hey, this is a safe thing. It's probably going to be in your best benefits, especially if they're immunocompromised, especially if they are at risk. Or for instance, they're going to be exposed to little kids, right? So we want to make sure that, if they're going to be around infants, maybe get your vaccines up to date, because you want to make sure that they're not going to be potentially exposed. Now, the big concern for a lot of those patients, a lot of people, were the links between autism and vaccines. And so the CDC has a nice page on this. You can send them to this. Obviously, is it going to be able to ease the minds of everyone who's concerned about this? No, some people are very much kind of set in a certain mindset. That's okay, but the actual evidence, when they actually did the studies, they looked at all the pooled data together of every patient here that were concerned with thimerosal causing autism, and they found no definitive link there. There's no strong link saying that, yes, this is an issue. Something going on back there? Oh, you hear children in the hallway. Okay, very good. It's probably my cue. I should wrap it up at some point, right? Anyway, so again, what they're saying here is that there is no definitive link between these two. And again, some people will be like, well, the CDC is part of the government. That's what they want you to think. All right, well, there's some people you just can't convince, right? But you can at least show them the evidence, show them the information, and try to convey that, hey, they haven't really found any link. And if there was something there, chances are we would have seen it based on the millions and millions and millions of doses of vaccines we've administered, right? So let's do a 10-minute break. We'll come back and then hit the rest of this section. So looking at the childhood immunization schedules, again, I said I'm not going to have you memorize the entire list. That would be silly. I'm not going to say like a 18-month-old child shows up for his well check, what vaccine should he get? Like, that's something you can look up, or you'll just kind of know after a while. But here's a list of common vaccines we do recommend for children, and I'll show you what the actual schedule looks like in just a little bit. Sometimes you'll see that the dosing will change based on, for instance, is it the first time they're getting the flu vaccine, right? We may give 2 doses instead of 1. Different things like that can actually affect the schedule. In general, we get a new schedule released yearly in January. I used to put a screen capture of the schedule, and I was like, man, I had to change this every single year. Let me just go to the website. So we'll go to the website. So where do you get the schedule from? The Centers for Disease Control. I guess they go to the CDC. Anyone know where they're based out of? Atlanta, yep. So anyway, so what you can do, and this is handy, is you'll find there's a couple of different charts that are here. So for instance, you have the one that's by age. This is kind of your general, kind of works for everyone who's coming in for the routine vaccinations. There's one that's going to be for a catch-up schedule. So if someone was late potentially, it'll tell you how far to space these different vaccines apart from one another, the different doses, to ensure you get appropriate immunization. And then we have one by medical indication. So if you have someone who has a certain disease state, which ones should they get, maybe in addition to other normal vaccines, which ones should they avoid entirely? And so you can actually look through this, and it's a very handy sort of schedule. So anyway, so you can see this is a 2020, this is for the 18 years or younger. And so you can see, for instance, okay, at birth, all right, they're gonna get Hep B right away. So they're probably gonna get that while they're still in the hospital after being born, or maybe at that first visit. And then during the first 2 months or so, you get the second dose. And then you notice here you wait a few more months, and then you get that third dose anywhere in this time frame. Okay, so basically you can see where things line up and administer those doses. Again, if you can give them all together, that is pretty beneficial if possible. You'll see here for things like, the influenza, right? This is the annual vaccination. The first time they get it, they should actually get 2 doses, right? To make sure they're going to get adequate immunization that first time they receive it. And we'll talk about a little bit more about that in just a little bit. But anyway, it's pretty self-explanatory, I think, in terms of like when you're going to give different vaccines. Or for instance, here, like the rotavirus, actually the first dose is like an oral one they'll get in the office, and then they'll get injections followed up after that. Different things like that. We'll talk about more specific vaccines as we go forward. Let's see. And then of course, this is the later one, so 18 months to 18 years. See things slow down pretty significantly, especially as they approach age 2. And so every time my kids go to the office, I'm like, oh, did they get any vaccines? And she's like, nope, they don't need anything for like a couple of years. I'm like, awesome, that's great. Because I always forget the schedule too, as it turns out. And I work in pediatrics. I'm just saying. You gotta look this stuff up. I mean, it's easy. And again, other things to note with medical conditions, again, just be cautious and look this up. So for instance, if it's yellow, it says go ahead and do it according to the normal schedule here, versus if it's red, it's not going to be recommended for certain populations, right? So you can look here through this. So for instance, you can see like the immunocompromised individuals or the live attenuated influenza vaccine. Notice here it's a contraindicated in several different disease states because it's the live attenuated form versus the inactivated form. This is the intramuscular one. This one they can get pretty much across the board, no problem. So again, intuitively, you'll kind of know that because conceptually say, okay, well, I know these immunocompromised individuals, they're more at risk for developing actual disease from a live attenuated form. Let's give them the inactivated. That makes pretty good sense there, I think. So, looking, oh, sorry, that someone's saying something. So looking at the adult immunization schedule, you'll see that typically this is going to be, in some cases, on a case-by-case basis, depending on disease state here. Most adults, they do recommend, routine tetanus, MMR, varicella, and then influenza. Certainly, they're going to get that every year. And then as they get older, you may start to consider different vaccines. So for instance, once they get above 65, they'll consider adding on the pneumococcal vaccine, because we know that pneumococcus in that age population tends to be much more severe as they become older and a little bit more immunocompromised. And then immunizations will be for certain specific needs. So for instance, if they have maybe exposure to meningitis or something, we can get them vaccinated there, or for certain international travel, for instance, which fortunately none of you will be going on for the next 30 days or so. So anyway, so looking at the adult schedule here, I'm really putting my lectures at a certain time and place, right? When you go to watch the videos. Like, what? We couldn't travel anywhere? So anyway, so these are good because these, again, will tell you either by age or by indications here. And the by indications one is really handy if you have patients with like autoimmune conditions, they have HIV, different things like that. So for instance, here you see the the inactivated vaccine or the recombinant influenza vaccine. They can get just one dose annually. Everyone should be getting that basically. Versus, say, for instance, the live attenuated, they only give it up until age 50, and afterwards they don't recommend that anymore because of either risk for not developing an adequate response or because of actual disease risk in those patients there. Notice here we can give tetanus boosters every 10 years or so. And frequently, say you have a patient comes in with like an injury and they're like, I don't know when my last one is. What do? Give to them anyway, right? So again, the risks are fairly low for giving it, and the benefits are only apparent there. They've been potentially exposed to something like tetanus, right? Or for instance, like pertussis is a really big risk, especially in infants. And so like when my first child was born, like my wife, myself, and my mother-in-law who helps care for her, all got our Tdaps at the same time. So that way we make sure that we were protected against pertussis in that really, kind of at-risk population age, right? Anyway, looking at the by indications one, again, you'll see that they will have different recommendations here. So for instance, yellow means go ahead and vaccinate, versus like red means don't give it to them at all. So for instance, with like MMR being a live vaccine, they don't recommend it in pregnancy or if you're immunocompromised, right? Or for instance, there's certain ones like, let's see where I'm at. Trying to find, or you notice here like end-stage renal disease, like why are they on this list, do you think? Because they're constantly going into the dialysis center, they're at risk for healthcare acquired diseases. Also, they're somewhat immunocompromised just by all that medical stress, essentially. So, so they may have certain recommendations for them as well. So again, if you're not sure, just go ahead and go back and look at this stuff. Or look at the HIV patients. If their CD4 count is less than 200 versus greater than 200, that can make a difference, right? If it's less than 200, they say don't give them any live vaccines, versus if they have a pretty well-constituted immune system, evidenced by a CD4 count over 200, they're okay to get it, right? So differences there are going to be important to look up based on your particular patient population. So, hope that makes some sense. So as I mentioned, immunizations will be different depending on specific individuals. So for instance, they have HIV, pregnancy. We already saw a few of those already. Also think about healthcare personnel. Like what are we potentially being exposed to that we should also get vaccinated against, or potentially boosters checked for? So I've mentioned like Hep B. Frequently, if you work at a hospital, they'll check your titers to see if you need another booster. But again, look at those contraindications as well. So in terms of other special populations with infants, we know that the mom is potentially transmitting antibodies, especially during the third trimester, and then certainly through breastfeeding to these infants. And so that does inhibit the immune response to live vaccines. And so this is why I see a lot of those are not going to be scheduled out until 12 months. So presumably for that first 12 months, they'll be protected via the mom, and then afterwards they'll actually find they can get a good response to that vaccine there. So that's the reason why we wait 12 months for the live vaccines in those patient populations. Again, if you have a premature infant, even if it was born at say 24 weeks or something, you're going to see that we'll be dosing this based off the postnatal age, because again, the risk is going to be the same, if not higher, because we know that the more premature they are, the more at risk they are for developing some of these diseases here. Generally, with pregnant women, the benefit outweighs the risk in terms of vaccinating, and so we don't really know too many adverse effects in terms of vaccinating here, and that's why we want to go ahead and still recommend the influenza to them every single year, just to avoid the live attenuated forms for those patients, right? Again, we mentioned the Tdap during the second or third trimester. That helps to mitigate some of that pertussis risk, not for the mom, but for the infant being born. And as I mentioned, due to theoretical risk, not anything we've actually seen in clinical studies, they avoid the live vaccines, may defer those potentially until after the birth of the infant. For immunocompromised individuals, and this includes a lot of different things, whether they're on chemotherapy, maybe they have a congenital immunodeficiency, all these things, or potentially if they're on steroids, right? Think about corticosteroids as being an immunocompromised state, especially if they're on, say, greater than doses equivalent to prednisone, more than 20 milligrams in a day. Now, does this include, like, if you got a 5-day course for bronchitis or an asthma exacerbation? No, this is like chronic therapy, rheumatoid arthritis, things like that, especially for more than 2 weeks, right? Now, this does not include things that are given via like meter dose inhalers. So if they take, for instance, Flovent for their asthma, that does not count because, again, it's not really getting much systemic action there. Intraarticular dosing does not count either because, again, limited systemic exposure. So in those cases that they're not considered immunocompromised, we would not treat them as such. But if they have rheumatoid arthritis, they're on, say, 30 milligrams of prednisone a day, absolutely they're included there. And again, they should be avoiding live vaccines. Other ones may not elicit a full response, but again, the potential benefits are there, so we would go ahead and still vaccinate in that patient population with inactivated forms. Okay. With healthcare personnel, certainly we recommend getting annual flu vaccines, and in most cases, like for instance, if you're in a hospital and you'll have, I don't have my badges on me, but I have one that says like vaccine 2019, 2020 to show that I got the flu vaccine for that particular year, because otherwise what do I have to do when I work in the hospital? Yeah, you got to mask up the whole time. And so have I heard of maybe some personnel perhaps stealing a badge to make sure that they don't have to get the vaccine in their form of, some disobedience, civil disobedience? Yeah, it's not great, right? Because again, they're putting only their patients at risk. And so that's really the concern with that. Certainly hepatitis B, we will be checking for titers for that. And then certainly recommend they get up to date with their series or get a booster for their Tdap, right? So I'm going to say Tdap, what does that stand for? Diphtheria. What's the A? Acellular pertussis. That's what that stands for. It's not and pertussis, but acellular pertussis. So we'll look at that in more detail in just a little bit here. But again, that's another thing. Those are common ones that we would like to make sure healthcare workers are going to be protected against with their patients. Other things to consider as well include like varicella, so especially if they never had chickenpox as a kid. We can try to help vaccinate them there. MMR, this is actually going to be if they're born 1957 or later without any kind of evidence of immunity. Most patients have probably been immunized against that already anyway, so that shouldn't be too big of a concern. And then meningococcal potentially, and this is actually a very specific case where actually microbiologists who might be exposed to Neisseria isolates may want to get this or will get this just to make sure that they are protected as well. So sometimes it can be very specialized. Okay, so let's look at a few vaccines in depth. HPV is a good one. This one is pretty cool because it helps to prevent cancers in some cases here. And we know there's a lot of different types of HPV that are out there. There's over 100 types, but there are certain ones that we are a little bit more concerned about than others, right? We know that there's some that are very likely, because HPV causes what? Cervical cancer, but routinely causes genital warts, right? So that's a concern there. So we know that there's certain high-risk ones that are more likely to cause cancer, but certainly we know there are also really common ones that we can try to protect against. So for instance, and I'm not going to ask you the specific types, 16, 18, 31, and 45, like I'm not going to put 17, 15, and 32, and 43 and expect you to identify. That's silly. But just know that there are certain high-risk types that are more likely to cause cancers, and there are some that are just much more common, more likely to cause the actual genital warts that we're concerned about. So guess who has HPV? A ton of people have HPV. Is it probably underdiagnosed? Absolutely. Most STIs tend to be underdiagnosed in those cases there. And again, they thought about over 80% of sexually active women have acquired HPV by age 50. It's quite a significant number of people who have that. Also very common in men. But again, we tend to see females tend to be a little bit more symptomatic than male patients will be. So again, the reason why we cared about this is because the really high-risk HPV types have been detected in almost entirety of all the cases of cervical cancers there. So we know if we protect against some of these more problematic types, we can prevent a large number of cervical cancers from ever occurring in the first place. So in these cases here, we find that like type 16 and 18 are going to be associated with, say 70% of the cervical cancers and even anal cancers in men are caused by these two types here. And then the genital warts, 90% are caused by 6 and 11. So if you could target just these 4, that would actually be really handy because you could prevent a lot of cases of just genital warts in and of themselves, and then also a lot of types of cancer, right? So, and as I said, most patients tend to be asymptomatic. They have no clinical disease whatsoever. So what does that mean in terms of transmission? It's really easy to transmit it because you don't know if you have it or not in some cases there. And so, again, we know the actual manifestations here, certainly anogenital warts are probably the most common things, but there's even cases of recurrent respiratory papillomatosis. There are cervical cancers, but not just cervical cancer. We also see things like penile, head and neck, anal cancer, a lot of varieties there. So it's not just the cervical cancer you think about, even though that's a pretty common one. So what do we have? We have Gardasil, and so this is actually approved back in the FDA back in June 2006. So this is kind of a cool one because it was relatively new in the grand scheme of things. It's kind of adapted what types it's covering for, and then also who we give it to over time. Because initially, who was it recommended for? Just female patients, right? They're age 9 through 26. So if you were, say, 30, and you want to protect yourself from HPV, it was not recommended initially there. And it was really just indicated to help prevent cervical cancer, which makes sense because it was only targeted against for those high-risk types and the very common ones, so 6, 11, 16, and 18, right? If it only protects against 4 strains of a particular virus, what do you call that? Quadrivalent, right? So this is initially just a quadrivalent vaccine, and they would give it as 2 to 3 doses, and then typically, as I said, you'd be giving it at least 1 to 2, 4 weeks apart between the first and second dose. And you notice here there's a 12-week period where you're going to give the immune system time to kind of ramp down a little bit, and then you re-challenge it for that last round in order to get full immunity. Since then, though, there are types where we only covered for 16 and 18, right? So it's actually just covering for the high-risk cervical cancer-causing types. This one's not quite as common. But then we have Gardasil 9. So this is really kind of the most common one you run into now. If it has 9 strains that it covers, what do you call that? Nonavalent, right? So it's a nonavalent vaccine that covers for all these different types. And again, I'm not going to ask you which type it is, but this is why we give the nonavalent type, because it covers for more strains of it, so you're more likely to help cast a wider net and prevent more disease from occurring in these patients. And so nowadays, do we give it just to girls? No, we give it to both male and female patients. Basically, anyone can receive it, right? And so usually around 11 to 12 years of age, they can be started earlier if you're worried about any high-risk behaviors or anything like that. They can start it at age 9 based on the clinician's discretion there. And then you'll see that, recommended for age 13 to 16, previously not vaccinated, and then for male patients 13 to 21 if they're not previously vaccinated. And then certain high-risk populations like they have HIV may also be recommended as well. Ideally, when do you want to initiate this? Before they start having sex, right? Because once they already have a strain, then they can't really be protected against that at that point there. So if possible, make sure to try to start it prior to the onset of sexual activity. I don't have to worry about this for my girls ever, so I need to do it right. Just kidding. They'll be getting this as soon as they can. Anyway, so again, if they already have a particular strain, if they already have disease, infection, this is not going to do anything for them. And so you're going to find that it's okay for females 26 or younger who have or are positive. So even if they already have evidence of positive HPV, they can still get the vaccine because there's many more strains that we can cover for potentially. If they're breastfeeding, immunocompromised, is still okay and safe to give. So this is a really good one that most patients should be getting if they're in that age range. Now, in terms of things like Pap screening and whatnot, that has not really changed at all. It should still be looking for that because, again, nowadays, even though we're covering for many types, there's still cases of cervical cancer that you want to be able to screen for there, even if they don't have HPV. So you still want to check for that stuff. And again, make sure they're being educated. Hey, just because you have this vaccine doesn't mean you're protected 100%. You still need to get your routine Pap smears done. Influenza, another really common one you're going to run into every single year, is going to come up. Again, we know that influenza is very transmissible via airborne transmission, large particle droplets, all of that. And again, we talked about how to treat influenza already. What do we use for that? Yeah, oseltamivir or Tamiflu, right? When do you want to give that? In 48 hours, ideally, right? So we know we have a way to treat it, but how can we prevent it in these cases here? Right, and again, the big problem here as well is that asymptomatic individuals can still be shedding the virus even if they're not having any symptoms. And again, when do we normally see the peak occurrences? Yeah, we're kind of on the tail end of it now, but depending on the year, you may see it extend out in either direction potentially. But typically, we'll start looking at getting our flu vaccines in for the hospital, around an October timeframe. We always do a flu blitz where we try to get everyone in the hospital vaccinated and recommend to our patients and whatnot. We're kind of past the peak months, hopefully, but we're still seeing quite a lot of respiratory patients showing up at the ER, and very frequently still getting a lot of influenza A and B being detected there. So basically, we're going to recommend this for everyone 6 months and older who does not have an actual contraindication to the vaccine itself. So we formulate it annually, and originally we just had a trivalent form, only covering for, I think, 2 strains of flu A and 1 of B, I think. But nowadays we have, yep, it's right there on the slide, I was right. I really don't read off my slides, I just kind of talk. And hopefully it matches up with what's on there. But nowadays we do have the additional quadrivalent. We have an additional strain of B that we cover for. That was a big one when H1N1 was a big deal back in the day. Not all that too long ago. So we have a lot of different varieties that are out there. So I'm sure some of you have probably received the intramuscular form at some point in your life. But we do have things like the flu mist as well. So we have different varieties, different brand names based on the route that are going to be given there. And again, everyone greater than 6 months should be getting their annual vaccine. And then usually kids less than 9 years who are getting vaccinated for the first time should get 2 doses, right? So the first time you get vaccinated, give them 2 doses. Even if they delay and they're 6 years old, go ahead and get it. And they wait 4 weeks in between. Make sure they get good, adequate response there. And you can still give it at the same time as other vaccines. That's no problem. Now again, how do we determine which 4 strains of flu we're going to be shooting for? That's a good. Yeah, we kind of guess. Like, we try to make educated guesses. We probably do. Maybe it comes from Australia. Actually, I haven't dug that deep into it, so maybe you know more than I do on the subject, perhaps. Go look down under. See what they have. But epidemiologists will do modeling and will try to determine what they think are the 4 most likely. Do they get it right every single time? Do they get it right anytime? Sometimes, right? But we still have cases of flu that happen even in people who are vaccinated. So that's another good education point. Just because you had the flu vaccine does not mean you're 100% protected by any means. There is a recombinant form that we have, and this is actually made without egg proteins, and so that would be a good thing if patients have a true anaphylactic allergy to eggs. I pity them. Sad life. I can't have avocados, so a lot of people pity me for not being able to eat guacamole, but I get really severe GI reactions. You don't want to see it. It's bad. I wouldn't say allergic necessarily, not like anaphylaxis, but I have a bad reaction to avocados. And people are like, oh, I'm so sorry for you. You can't have guacamole. And I'm like, I know. But no eggs? That's like everything. Regardless, have it made without egg protein, so that would be a good alternative to them. So flu mist is probably the most common one you're going to run into in terms of a live attenuated form. This is going to be the intranasal formulation there, and this is going to be basically from ages 2 to 49. That's what it's actually approved for. If it's less than age 2, then you go ahead and give the inactivated intramuscular form. If they're greater than, they're 50 and up, give them the inactivated form as well. And again, the same goes here. If they're 2 to 8 and they're getting the flu vaccine for the first time, they should still get 2 doses of the live attenuated form. So that recommendation does not change. It's just that if they're less than 2, then they're going to be recommended to get the inactivated form. Here, they actually wait a little bit longer between doses, around 6 to 10 weeks or so between those. And again, because this is live attenuated, they cannot get this one at the same time. Or they can't get at the same time as anything else, but they got to wait. If they're going to get another live vaccine, you have to wait at least 4 weeks, right? So for instance, if they were to get their MMR at 12 months, actually that doesn't count because they're not going to be old enough for that. Let's say they're delayed in getting their MMR and they weren't going to get it till they were 2, they have to wait at least 4 weeks before they can get the live attenuated flu vaccine, the intranasal form. Okay, so just little things like that you want to think about. So with flu mist, contraindications include they have severe allergic reaction to egg proteins, right? And also they have concomitant aspirin use in these children and adolescents. They can have higher likelihood to have a reaction there, so you do want to watch out for that. And again, we're not going to recommend this for patients who have any degree of immunocompromisation, no pregnant patients, because it is a live attenuated form, right? And then also you probably don't want to give it within 48 hours of antivirals because it could interact with how well it's going to work. Because again, the antivirals could go and interact with that, the actual live version of the virus and prevent it from being all that effective. Okay, let's talk about rabies real quick. What kind of animals are at risk for causing rabies? Bats. You always think about bats? If you wake up in the middle of the night and you notice a bat is in the corner, you automatically assume you've been bit, right? The bat bites aren't actually all that present, or it may not be obvious to the patient there. If I ever woke up with a bat in my room, I would likely burn the entire house down. So I have more things to worry about than just rabies. But yeah, safety precautions, absolutely. Have you guys ever seen that movie The Great Outdoors? It's John Candy and Dan Aykroyd. It's like an 80s movie. It's a classic, very funny movie. But they have a scene where they're trying to get a bat out of the house. It's very funny. I'd recommend YouTubing that. Anyway, so the interesting thing about rabies is that while it is quite rare for it to actually happen, once patients become symptomatic, it is almost 100% fatal. There's very few cases of people actually surviving this, which is why we do worry about this quite significantly if it do have a high risk exposure. And annually, you'll find that across the world, there are many more deaths associated with this. You'll find that here in the US, do we worry about like dog bites as being a high risk cause for rabies? Typically no, but if you were to go, say, outside of the US and go to other, say, more developing countries, you will find that stray dogs and things like that are much more likely to be there. So you'll find that the animal diversity will change on what we're really concerned about here in the US in particular, which is what we'll focus on. We maybe have about 3 cases per year in the US, so we have a very good means of trying to prevent this. Because again, a lot of animals, domesticated animals, are being vaccinated against that. And interestingly enough, it's found everywhere except for Hawaii. Because whatever animals they have there are unlikely to carry rabies. And so it's almost always through a bite, although rarely you could have it with like aerosolization, transplantation, again quite rare, but this could occur. You'll see that dogs in developing countries, as I mentioned, about 90% of the cases there are responsible for rabies. In the US though, we think about things like bats, we think about raccoons, your skunks, foxes and all that. Cats and dogs are very low risk for the most part here in the US at least. Does that mean that they can't get it through that? No, there are some rare cases, but it's unlikely, right? So what happens is essentially, it's kind of interesting how the virus will get into a peripheral wound. So say for instance you get bit on the hand, it will then actually travel up the nerves and into the brain. And once it's there, things get pretty bad at that point. You'll see that it can then get into things like the salivary glands, which makes sense how it is transmitted through a bite. And you'll see things like how big of a bite, how significant it was, how much was actually inoculated, can make the difference in terms of how high risk the infection is going to be for those patients there. And you also think about the distance from the bite to the brain itself can make a difference there. So actually the site innervation, how innervated it is can mean the difference there in terms of the time frame there. And obviously host immunity makes a difference as well. And so you'll see a host of different symptoms here. They talk about the encephalitic or the furious symptoms. This is where they get hydrophobia. You know what that is? It's scared of water. There's aerophobia. Scared of air. Yeah, it's weird. There's some videos online you'll find. There's like a case where a patient was, I think unfortunately he died, but he was very symptomatic and actually like they were like putting like little puffs of air towards his face and he was just like freaking out about it. Like it was really kind of strange seeing kind of the symptoms there. The paralytic symptoms also can be quite severe in terms of like quadriparesis. This is usually a little bit later when that sort of develops. And so what happens is they get this incubation phase where they may have really no symptoms, and then once they develop sort of these acute neurologic syndrome, it's kind of downhill from there. So there's very rare cases of any survivals. Although the case reports, you should look those up because they're really kind of interesting how much, basically they put the patient into a medically induced coma essentially and just supported them until they kind of cleared the virus itself. Very fascinating to read about. But typically in terms of incubation, it can be 1 to 3 months on average, but it could be several days depending on the type of bite, or it could be up to a year in some cases. And as I mentioned, bites closer to the brain typically are going to be incubating faster, whereas if it had like a bite on the foot, that would be actually the slowest. It makes sense as farther to go. What we like to do is do good wound care. Soap and water does go a long way here, and maybe even using virucidal agents like betadine, which is povidone iodine. That helps to reduce a lot of risk there. And then we think about things like antibiotic and tetanus prophylaxis potentially. You know, for instance, you know, if they have a cat bite, anyone know what you get for a cat bite? Yeah, Augmentin is actually the recommended drug of choice there. So depending on the animal and the type of bite it is, you may want to give prophylactic antibiotics. You know, you think about things that are growing in the mouth. We actually had a case a couple years ago where someone got an alligator bite, and they're like, "What antibiotics do we use for this?" And I was like, "I don't know. I'm going to look it up though." So you have to worry about things like typical anaerobes, but then also like some waterborne stuff, you know, so like Vibrio, things like that. So it's kind of interesting. Regardless, though, also look at their tetanus status if they need to be updated. Do that. So here's the new drugs that we'll be using, or new to you drugs that we're going to be using for this. And so first off, we have the rabies immune globulin, and so this is actually the actual antibodies itself we're giving to the patient. And basically, there's a couple different brand names you're going to see here for it. There is a human-derived version, which is going to be much safer because much lower risk for anaphylaxis in those patients. And there's an equine-derived version, but we don't use that as often. And basically, this is nice because this provides immediate neutralization. As soon as the antibody comes in contact with the virus, it'll neutralize it and is done. So what's interesting in terms of the administration is we'll actually give it around the bite site. So you'll have a particular dose, how many ever mLs of a dose you're going to give, and you'll infiltrate it around the bite. And then if you have any left over, then you can give it into an intramuscular site. So that way it helps to neutralize whatever's there, especially if you get it really soon after the bite occurs, within say a couple hours. Now, in terms of the vaccine, you'll find that patients will start to develop antibodies around 7 to 10 days or so after being started, and will persist for several years. So, do you think there's anyone who gets this prophylactically? Yeah, maybe like vet trainers, or they do like animal control, things like that. They may vet trainers, that doesn't make sense. Maybe. You said bat trainers? Bat trainers, yes. Batman, potentially. I don't know. Like, did you watch like The Dark Knight when this is all flown around? I'm like, any one of those could have bitten him. He needs to go to the hospital. But so we do have a couple of varieties of the vaccine that are available. None, not one that's kind of preferential to the other here. But you'll see that some patients will require pre-exposure prophylaxis. I think about animal control and patients or people who are going to be going into people's houses to get those bats if they had not already burned them down, for instance. Most of the time, though, that we'll be seeing them, especially like in the ER setting, is more for post-exposure prophylaxis. So that can make a difference there. Again, this is another one that doesn't really work well in the gluteal area. We'll do it in the deltoid as a preferred site. And so what's interesting here is that patients will typically get the first dose here in the hospital in the ER setting, and then actually, who follows up with them? The health department actually does. So actually the Florida Department of Health will follow them up and make sure that they go and finish their full course, because you don't want someone who is potentially exposed not finishing up their full course here, because again, it is another 4 days or 4 doses they're going to be requiring there. And so basically we'll get a dose on day 0, which is probably when the bite occurred, and they'll follow up at 7, 21, and 28 days. Again, after we give them the first dose and we're kind of done with it, we'll report it to the Department of Health, and then they kind of follow up with the patient there, which is nice. And so just to give you an example, looking at this, an algorithm on what to do if you have one of these bites show up, right? You always want to have a nice systematic approach to these different types of exposures. But you think about here, okay, was a mammal that bit the patient, so you're not really worried about like a snake bite causing rabies, for instance. But was it a mammal? Or did they have a contact that was high risk enough that you're really worried about it? And if the answer no to all those things, then no post-exposure prophylaxis is really needed there. But then you can kind of look at different risks of different animal types. So for instance, if it's a high-risk animal like a bat, a raccoon, a skunk, a woodchuck, who knew a woodchuck could be so dangerous? Then you have to think about, is the animal available? Can you quarantine them? Can you do the testing? The only way to do definitive rabies testing is actually after the animal's dead, unfortunately. So if it's like a household animal, they'll usually quarantine it for a period of time. And then if it's not available to test, you just go ahead and start the post-exposure prophylaxis. There are cases where you can go ahead and wait and test the animal and then see if you need to start it regardless. So there could be a waiting period there. If it's a low-risk animal like a squirrel or say like a rabbit or a chipmunk or something like that, actually no post-exposure prophylaxis is really needed there. It gets more interesting when you get to like dogs and cats or ferrets. Again, who knew a ferret could be a potential reservoir here? Again, you ask about, is it unavailable? This is typically a pretty low risk category because most cats and dogs have probably been vaccinated already. And so again, if it's healthy and available for quarantine, then you can do a 10-day period, see if it develops any symptoms. If not, then you don't have to do anything with your patient. Otherwise, you go ahead and can start the post-exposure prophylaxis. So, and then little pocket animals, they're really not a lot of big risk there. But again, who can you always contact about this stuff if you're not sure? Department of Health really helps out a lot with that, so they can always call them up. If you had a rabid cow bite, I don't know if that's ever happened, but I would call the Department of Health just to be sure. You have a question?
Yes. So for infectious disease, I think we learned that it was days 0, 3, 7, and 14 for the rabies shots.
I might have the pre-exposure prophylaxis scheduled there. It might change there. I'd have to look that up though, to be sure. I would test whatever they taught you there. I would know that for their test. I'm probably not going to ask you the scheduling on my test. Probably. It's not 100%, but probably. Greater than 50% chance I'm not going to ask that question on the test. Anyway, so Again, for the high-risk patients, we typically give the immune globulin and the antibody or the vaccine at the same time, and then it can follow them up. So it's not uncommon to see those two together. Tetanus, we'll talk about real briefly. This is an exotoxin of Clostridium tetani, and so this is the only vaccine-preventable disease that's actually not contagious. So where do people usually pick up tetanus from? Stand on a rusty nail, or they get into say an accident, say for instance like you're riding a motorcycle and you get scraped along the ground, you know, anything like from the ground can have this Clostridium tetani there. And it's the exotoxin we're really worried about. What's interesting is it will block the release of things like GABA. And so what would you think would happen if I block GABA from being released? Very hyperexcitatory, so you can see this continuous muscle spasms that can occur. There can develop things like rhabdo potentially. It also can affect the autonomic nervous system, develop aspiration pneumonia, a lot of really bad things. We try to prevent this as best we can. Fortunately, a lot of patients are already going to be protected against this. In some cases, we go ahead and give the tetanus toxoid. So this is actually something that patients can actually have the response to and develop immunity to it. And basically, we'll actually give it this, I'll have it adsorbed onto aluminum hydroxide and some other salts, and that increases the antigenicity, increases it so that patients are more likely to have a response to that. And typically, we get response for about 10 years or so, and that's why we end up giving those boosters every 10 years. When it's given for wound care management, typically it's going to be the TD form you're going to see. And so this is another one of those ones where you have kind of alphabet soup. But TD stands for tetanus and diphtheria, right? So you're kind of covering for both of those at the same time. And you'll usually see it with acellular pertussis, right? So for instance, with Tdap, generally for patients, what kind of age frame? You guys know? Tdap. Yeah, older, usually over 7, they'll get Tdap, and then less than 7, they'll usually get DTaP. I know that's confusing. Usually it just changes the dose of what they're getting, so the diphtheria dose is going to be bigger. That's why it's a big D in the DTaP versus the TD AP is going to be for your older patients there. And then occasionally, if we have a patient who maybe is unvaccinated or they have a really high-risk wound, we'll actually give the tetanus immune globulin so that they were releasing any of that exotoxin, just go and bind that up prophylactically. And so as an example here, here's another sort of algorithm we can look at to see, okay, well, you know, what kind of wound do they have? And then, you know, what do we know about their vaccination status there, right? So for instance, someone who has, you know, unknown dosing here, you know, and it's a pretty clean minor wound, maybe you want to go ahead and give them a booster if you're not sure, but maybe you don't want to require the tetanus immune globulin. Obviously, giving the immune globulin is much more risky, it's more expensive, so if we can hold off on giving that, we usually try to, unless it's a really high-risk patient. So for instance, here, if it's a really sort of major injury, maybe it was a motorcycle accident or something, and we did not know what their vaccination status was, you may go ahead and just give both of them at the same time just to provide a little extra protection for the patient there. Otherwise, if they're fully well vaccinated, it doesn't really matter within the past 10 years, you don't have to really do much for them, right? It's only if you have an unknown status or if you, you know, they're outside of that 10-year window, just go ahead and give them another dose. I only know when I got my last dose because I knew it coincided with when my child was born, for the pertussis risk, but otherwise I don't think I would have known when the last one was anyway. So you guys know? You're probably better historians than I am then. Anyway, so next let's look at immune globulin more specifically. So this is kind of a general broad sort of umbrella of just immune globulin. This is again pulled from donor plasma that's been purified essentially, and so as you might imagine, it has a wide variety of activities against whatever antibodies that those donors had. You'll then have antibodies when you give it to your patient, and the nice thing here is the half-life's around 18 to 32 days or so, so it does provide nice long coverage for about a month for many patients there. And so we may give it for several different conditions. We may do it for things like if they have a primary immune deficiency where they don't develop their own IgG. This is a good replacement for that. Or we may do it for certain indications, things like ITP we can administer for, Kawasaki's disease. It tends to have sort of a help with certain autoimmune conditions to kind of help tamp that down to some degree, which is helpful. In terms of adverse effects, though, because you're giving a patient someone else's proteins, the risk for sensitization, anaphylaxis is certainly there. And you also will see a lot of infusion-related reactions as well. So you see things like fevers and chills, nausea, vomiting. And so frequently what we'll do is we'll actually titrate the dose that we give and see how the patient responds to it. So for instance, we may start them only getting, say the full dose is say 500 mLs of IVIG you're giving. We'll start at like maybe 5 or 6 mLs an hour and see how they respond. If they're doing okay, then we'll bump them up a little bit higher and higher until they can kind of get their tolerated dose, and then they finish out the infusion. For this, what do you think I could give to prevent some of those infusion-related reactions? Well, just like when we were looking at things like infliximab and those monoclonal antibodies, you can get things like Tylenol, you can get things like Benadryl potentially, maybe even some steroids potentially. I've seen some patients require steroids prior to getting IVIG. So the same thing goes along with that. There's infusion-related reactions. Typically, though, we just slow it down for the most part. These tend to be very expensive. So if you think about a typical dose for a patient being, say, 0.5 to 1 gram per kilogram, this gets pretty expensive pretty quick. So if you imagine you're giving 50 or 100 grams to a patient at $200 a gram, the costs rack up pretty quickly there. And you'll find there's a lot of different brands that are available. If a patient has a reaction to one, we can typically switch them to another brand and they're going to do okay with that. So I have patients who maybe are allergic to Privigen, which is like our formulary item at Nemours. We just switch them over to something like GammaGuard or Gamunex, for instance. Just know there are different varieties out there patients may be receiving. Be aware though that, like, for instance, if you have like a Jehovah's Witness, like, they're not going to want to receive this because it is donated from other people, and so just like a risk with blood transfusions, it would go against their religious belief. So make sure you're screening for that as well. And then we have RhoGAM or Rho-D immune globulin. Who's going to receive this? Usually pregnant women are going to receive this. Another form of immune globulin we give that's specifically against the Rho-D erythrocytes that express that. And so basically we're going to be giving this to women to prevent hemolytic disease of the newborn in mothers, right? So when does this occur? You guys covered this before? So if the mom is Rh negative and the baby is Rh positive, mom can develop antibodies against that, right? And again, it may not be a concern with the first baby, but the second baby was also Rh positive, then that can be the really big issue there when you have that hemolytic disease. Mom's antibodies will attack those red blood cells and then lyse them essentially. That's not good for a developing fetus? No, it is not, right? So by giving this Rho-D immune globulin, we try to neutralize any of those antibodies that the mom might produce. So it's like an antibody against those antibodies there. And so you want to know the mom's Rho-D status is. If she's Rh positive, then obviously it may not be required in those cases there. This is another one. So this is one that occasionally you'll find that even if mom is Rh negative, you know the father to be Rh negative, they may still give it just to be cautious, because what could happen potentially? Because what if that dad is not really the dad? Never know, right? So in some cases, if the mom's Rh negative, it may be better to be safe than sorry, and they'll go ahead and administer the RhoGAM anyway. So certain time frames will do that, but I'm not going to get super into the details on that one. Any other questions? Unfortunately, I cannot deny my children. They look too much like me. At least my first daughter does. The second one, not so much. But I'm not really too worried about it. Anyway, any questions you guys have? Oh my goodness. Holy moly. I didn't want to...
Like one, just for added emphasis.
Okay, let's see. So what if they are 7 DTaP or DTaP? If they are 7 and up, we will do Tdap for them. If they're less than 7, we'll do DTaP. What is the prophylaxis for the gator nibble? I think we end up doing Doxy or Cipro. I'm trying to recall. I've had other marine envenomations where we did Doxy, but this one either, I think it might have been Cipro. It was not really a nibble so much as the chomp. If coronavirus were to spread through Orlando, maybe it already is, we don't know. Would it be possible for you to play your guitar for the... No, why would I do that? If rabies is so deadly, how can animals live with it? I am not a veterinary pharmacologist, so... Would a patient with with UC on mesalamine, standard adult dose daily, be considered immunosuppressed? If it's just mesalamine, that's a good question. I'd ask a rheumatologist, or actually a gastroenterologist. I would ask for that one. It's a good question, though. Actually, I don't know. Ask an expert is my answer there. There's a lot of these. I would ask someone else, like a vet. Any reason why you would prefer to use the live flu vaccine over the inactivated? If they are needle phobic and they want to use the flu mist, some people feel it's more convenient. They'll just do that as a strict nasal spray versus having the injection. Some people like that better. So that's the big difference there. Oh, this is a big one. I'm gonna save that one. Do you think it's okay to fly during spring break because of coronavirus? I mean, fly where? Italy? No, I would not. Not got much of a choice in your options in terms of international travel. Domestic travel, I would be just cautious. Right? Do your due diligence. Be careful, especially if you're going to be around patients who may be at risk, like those with comorbid conditions or elderly folks. I don't know if I would cancel my plans necessarily. I would just make sure I'm definitely washing my hands for how long? 20 seconds. Sometimes it feels like forever. It probably is, but I'm just Sing a little song to yourself. Imagine me playing guitar to 20 seconds. And what's your opinion of the coronavirus? Oh, wait, I already answered that one. Talked about that one. If you got one Gardasil vaccine, could you go get the 9 as well? I'm not sure. If you got the full course, I've never seen one actually go back. I think nowadays we only really do the nonavalent, but I'm not sure about those people in the interim if they would have gone back. I don't know if there's any risk by doing that, so it's probably not a contraindication, I would say, but I'd have to look it up. That was a very specific use case. Nope, your numbers are right for rabies post-exposure. Okay, really? That's good. I'll let you guys follow that link if you want. Okay. Also remember H1N1, 2 differences I see. Corona much more contagious. My college roommate got H1N1, I didn't. That is true. It is very contagious. Also, like, does anyone really have immunity against coronavirus? Not really. Not like influenza. Yeah, so reinfection is a risk there. More severe respiratory complications. I don't remember people developing severe pneumonia, H1N1, but correct me if I'm wrong. I have seen some severe cases though. So for instance, the first H1N1 case I actually saw was a 17-year-old female. She was like morbidly obese. She ended up on ECMO because of it. So she was on ECMO for probably 2 weeks before she was able to recover enough. So H1N1 was still pretty bad, but again, it was not as near as contagious, and just we were able to get a vaccine out pretty quick there. You think I can go to Italy in May? I don't know. I got a cruise scheduled in October, so I'm hoping things will be died down by then, but only time will tell. Okay, that's a lot of questions. Verify my information, please. Don't just take my word for all this stuff.